Alrighty, week one, term one of pharmacology. It's okay to be a beginner. This is really not as scary as it seems. Come on, there we go. This is off kilter. No, whatever. Okay, so be a good student, yada yada yada, good drug references. What's the one that I like? Lippincott. I think everyone's got access to Lippincott and up to date. Those are the best. Clinical pharmacology. You can zoom this in a little bit, a little better. So there are a few basic terms to remember with pharmacology. A drug is any chemical that can affect living processes. Pharmacology is the study of these drugs and their interactions with living systems. Is a very broad term. Clinical pharmacology is the study of drugs in humans rather than in monkeys or in mice or pigs or whatever. Pharmacotherapeutics are going to be the use of drugs to diagnose, prevent, or treat disease or prevent pregnancy. When it comes to the properties of an ideal drug, the most important one is going to be a drug's effectiveness. Because within the scope of a drug's effectiveness, we're going to have how safe is it, how selective is it. And so they kind of all combines into what is an effective medication. Some of the other things that we like to look out for good ideal drugs are reversible actions. Say we give too much an accident. If we have an antidote that's easy to give, boom, doesn't matter, we're good to go. Predictability, we know what to expect with the giving of certain drugs. So if we give a nitro sublingual tab for a patient who's suffering a heart attack, we can expect most of the time that his or her symptoms will be at least somewhat made better. Ease of administration, so giving a medication through an intraosseous injection into the bone is going to be a lot more difficult than giving a medication just by popping a pill in their mouth. Freedom from drug interactions, being that you can give all of these different drugs together that a patient may need, and hallelujah, they don't actually interact together in a negative way. That would be amazing. Low cost, because we want to care about the impact our therapy choices can make on a patient and their finances. Chemical stability, is this drug going to change as it sits on the shelf or while it's in the patient's belly? And then a simple generic name helps a lot towards identifying medications and communicating about those medications to patients or in the interprofessional team. But we're never going to get anything that has all of these guys put together in a great little easy way. It's just not possible. So we want to find the best way we can meet as many of these as possible while making it as effective as possible being the most important thing to provide the maximum benefit with the minimum harm. There's been some very important legislation that has occurred since medications have first started popping up in the US. I mean, they've been around forever, but back in 1906, I think was when we first started seeing medication legislation. The Federal Pure Drug and Food Act set the standards as a general baseline for drug quality, purity, strength, and labeling, and kind of got the ball rolling on getting any kind of regulations on drugs. The HK, I'm not going to pronounce that, amendments of 1962 were an amendment to the Food, Drug, and Cosmetic Act of 1938, which addressed, again, drug safety, because safety is one of the most important things. And safety, if I recall what Rachel said appropriately, safety is part of effectiveness as well. The HK amendments were in response to the thalidomide tragedy in Europe. So a lot of times, or back in the day in the 60s or 50s, Women were often given this medication, thalidomide, to try to help with, I believe it was nausea that they were experiencing. Little do they know that thalidomide caused very gross, not as in ew gross, but like very obvious, very large scale, gross development patterns in children, in newborns. Instead of having arms, they would have their hands and wrists kind of coming directly out of their shoulders, as opposed to having, you know, a humerus, radius, ulna, elbow. Making, you know, that's a big deal. And so from there on, they were forced to show that the drugs were to be proven effective. We also have some fast-track pediatric research legislation for the benefit of treating AIDS, cancer, and other life-threatening illnesses. The Best Pharmaceuticals for Children Act of 2002 and the Pediatric Research Equity Act of 2003 promoted research into the efficacy and the safety of drugs, specifically in children, because children and women have been shown to have very little research done as to the effects of drugs on them, which makes it really hard to figure out whether or not a drug is safe. So the research of efficacy, dosage, and safety are often overlooked. The FDA now can force pharma industries to do clinical trials specifically for women and children because we don't know how exactly they interact with women and children compared to men, and men have always, for whatever reason, been the ones doing this. And not all adverse effects, unfortunately, are detected through trials. So, unfortunately, we gotta kind of have to go through and see it firsthand. Oh, come on. The FDA is a U.S. regulatory agency that approves processes. The USP, the U.S. What is U.S. Pharmacopeal Convention? Is that supposed? Where's the C? I don't understand why that's their logo. This standardizes child specimens. Don't ask me what that means. Ensures identity, strength, quality, and purity of drugs. I don't think we ever talked about this after this slide, so I'm not going to bother too much with it. An RCT, everyone should know what this is at this point. It's the gold standard for trials with a treatment group, a control group, hopefully a double-blind blinding of the study so that researchers and subjects are both unaware of which medication they're taking. And drug names come in three fancy little names. We have the chemical name, which virtually no one in clinical care uses these names, like N-acetylpara-aminophenol, and, you know, acetaminophen is going to be what we're going to call it, and that's the generic name. This, in general, is the name we always want to go with because it is the universal name given to all drugs of that type, regardless of their trade or brand name. So we may have Tylenol, Feverol, Infantare. That's a horrible name. But for all of them, they're going to have the generic being acetaminophen. And that's the one we should use to communicate with patients whenever possible and try to encourage them to communicate with that because it just makes communication much more seamless. Am I really saying that right? Infantare? I don't want to, whatever. Over-the-counter drugs are very, very popular. It's good that we have some. It's a $20 billion industry, $20 billion industry. And 60% of all drug doses are, that's a weird sentence. 60% of all drug doses administered, I guess, are OTC. 40% of U.S. take at least one over-the-counter drug every 2 days. So there's a lot of them. And the unfortunate thing is that people go about getting over-the-counter drugs. Maybe they don't know how to take them correctly. They don't know how to read directions. They may have low health literacy, thinking, oh, this person that I know took this and they felt better, therefore I'm going to take it. but I'm also taking 15 other supplements or these prescription medications, but I'm not aware that I need to talk to my doctor about it, and so now I've got all these medications taken together and I'm having these nasty side effects that I'm not aware of, that it's because I'm taking meds without my doctor or whomever being aware of it. Pharmacokinetics. So there are pharmacokinetics and pharmacodynamics. So pharmacokinetics, what the body does to the drugs. I prefer to think about it more as how the drug moves through the body. Pharmacodynamics are going to be what the drug does to the body. So pharmacokinetics, we're going to have things such as absorption, distribution to the targeted cells, excretion, metabolism. I'm kind of going out of order here. And pharmacokinetics are going to be influenced by things such as age, a person's sex, their body composition, whether they have a lot of fat or very little fat, a lot of muscle, very little muscle. And a couple things to keep in mind here. These are little extras, but they kind of seem to help me understand things better. We have different types of molecules or drugs broken down in the body. We can have polar molecules and ions, and there are also like non-polar medications. There's just a couple that were from the book. Both of these are going to have a difficult time crossing plasma membranes. A polar molecule has no net charge, but the electrons in their shell tend to congregate towards one side. So we end up having a neutral net molecule with one side having no electrons, one side having electrons, making it a polar molecule. And they're going to dissolve, since like dissolves like, these polar molecules, and sugar is an example of this, can dissolve in polar solvents such as water. But things like lipids, oils, are nonpolar. And since like does not dissolve dislike, so water or polar molecules are not going to dissolve well in nonpolar mediums such as lipids, polar drugs therefore are not going to be able to cross a cell's phospholipid bilayer compared to a nonpolar molecule. Ions do carry a net electrical charge, and because of that net electrical charge, they are unable to cross cell membranes generally, I believe. I don't remember exactly. But very small ions can cross. I think more of that will come later. So we have first our absorption. So this can be from injection or from a pill that you've taken. The rate of absorption will determine how soon the effects begin. So if the body has to take it, and it has to go through the GI tract, it has to be kind of broken down in the GI tract like a pill, and then metabolized to some extent, it's going to take a while before it's actually fully absorbed and you're good to go. And that's how soon you will begin to feel the effects. The amount of the medication will help determine the intensity of the effects. So regardless of how you take it, if you take in, let's say an IV of an opioid of some form like fentanyl, the rate, because of the fact that you're giving it via IV, is going to be very quickly because that's going straight into your circulatory system. If you give very little, you're not going to have a very high intensity of effects. You give a whole bunch of it, you're going to have very high intensity of effects. But the rate, how soon it begins, generally will be about the same regardless of that amount. It's not always the case, but go with it. There are some factors that can affect absorption. So rate of dissolution. If the let's say we're taking a pill and that pill dissolves in gastric acid very slowly. Of course, that's going to greatly affect the speeds of absorption. It's going to go very slowly. The surface area of something, I guess whatever it is absorbing it, if there's a high level of surface area that's absorbing this chemical, then it's going to absorb it very quickly. If the area in which this chemical is absorbing through has a high level of blood flow, that blood flow is going to be continuously giving an opportunity, or is going to be giving the opportunity for the drug to continuously dump into the bloodstream and rush its way to wherever the target site is. And a drug that is more lipid soluble is able to be more rapidly absorbed into the body, since of course lipid soluble drugs can more easily cross cell membranes. And then pH partitioning is also important in regards to absorption, and that's where we had to come down here. Ignore the wall of red, this will make a lot more sense. So as a base review, an acid is a compound that can give up a proton, like a hydrogen ion, which that is the proton, not like, can give up a hydrogen ion. A base is going to be a molecule that can take on a proton. So when an acid gives up a proton, the acid then becomes negatively charged. And when a base accepts a proton, then that base becomes positively charged. That action of either one accepting or releasing a proton and becoming charged is called ionization. Acids will ionize in basic media, and bases will ionize in acidic media. So you throw something that's acidic into something that's alkalotic, it will ionize, and it'll be, we'll get to that in a second. So many drugs are going to either be a weak acid or a weak base, and they can exist either in a charged or a neutral state depending on the pH of the surrounding environment. Aspirin, for example, is a weak acid. So we've got our aspirin here, these little two doohickeys. They're acidic, they're in the stomach, and the stomach is acidic. And we're talking what, pH 2? Let's see here. So they can, being that it is not ionized, because a weak acid put into an acidic environment is not going to give off a proton. They're going to stay in this place. They're not going to be ionized, which means they're readily going to be able to cross the stomach, the membranes in the stomach, into the capillaries and into the cardiovascular system. Once the aspirin has gotten into the capillaries, whether that be through the stomach or the small intestine, wherever, it now enters into a more basic environment, because blood is 7.35 to 7.45, erring on the side of basic alkalotic. Once in there, the aspirin is going to give off a proton, and when it gives off that proton, it becomes ionized. And so it's not going to be able to leave the blood vessels and just kind of flush out to wherever it wants. It has to stay in the blood vessels at that point. And so that's where this pH partitioning comes in, is just that identifies if you put an acidic medium or a chemical of some form into an acidic environment, it's going to remain non-ionized, and it can go wherever it wants because it's lipid soluble. But once it crosses over into this basic environment, it becomes ionized, gives up this proton, and it cannot cross back over to the stomach or anywhere else unless it's being helped to get there. This can actually be really helpful in certain situations. If, say, a patient were to be poisoned with an acidic poison of some form, then giving the patient something to make the urinary pH higher will draw the poison towards that alkalotic urine, or at least when it goes into the kidneys, then it'll be drawn, attracted to, and made ionized in the urine, in the very basic urine, and will then be able to be flushed out. Because in general, acidic drugs will accumulate on the alkaline side of a membrane, and the basic drugs will accumulate on the acidic side. That's kind of a lot to go over there, little, maybe more than anyone wanted. I thought it was interesting. So we've got several routes. Overall, we have parenteral routes and enteral routes. Enteral being like a gastroenterologist. So we're talking PO, taking it by mouth per oral. We also have parenteral, which is going to be our IV or our so intravascular, intramuscular, subcutaneous. These are all going to be faster routes in general than our PO. We have other routes as well, but you'll come into those as you need to. There are no barriers to absorption with IV. You're poking into a vein and you're pumping stuff in there. For IM, barriers generally are going to be the capillary wall, but that tends to be pretty easy to overcome. Same thing for sub-Q. And then with PO, barriers to absorption tend to be the epithelial lining of the GI tract, the capillary wall, and just how well that medication is meant to cross into those areas. And the rest of that can read over. Distribution, so how well the drug can spread out to the tissues that it needs to get to. So the blood flow will determine that rate of delivery, how quickly you can get to wherever it needs to go. And then it will exit the vascular system between those capillary cells at certain junctions or whatever. I don't know what that's saying. So the blood-brain barrier is this really tight tissue section around the brain and spinal cord, and is actually composed of tight junctions between cells. Between cells and walls of them. Is made of tight junctions between brain tissue and capillaries. And the only chemicals that are able to cross the blood-brain barrier are going to be those lipid-soluble drugs or ones with a transport system. Some other ones sometimes can kind of cross. Yeah, okay, that's all there is for that. Placental drug transfer. So when a woman is pregnant, you need to stop saying preggers. The placenta will separate maternal and fetal circulation, but similar to a blood-brain barrier, there are exceptions. So the membrane of the placenta does not have or constitute an absolute barrier to the passage of drugs. So anything that is lipid-soluble, anything that is non-ionized, can readily pass from maternal bloodstream into fetal bloodstream. But those that are ionized or highly polar or protein bound are really not able to cross. And so, for example, if a mother uses opioids on a regular basis, they will cross, because they are lipid soluble, they will cross the placenta, and that baby can actually, the fetus can actually become dependent upon opioids. And they may actually need treatment upon birth. And the same thing goes with the use of respiratory depressants during delivery for the mother. Those can also cross the placental barrier and lead to a child, or a newborn baby, that is unable to be breathing on their own, and they have to now be watched for a number of hours until they're good to go. Most drugs have some form of protein binding in the body. And most of the time they bind to plasma albumin. And albumin is going to be the most important, the most abundant and largest protein molecule in the circulatory system. They always remain in the bloodstream because they are so massive. And they are able to affect distribution and interactions. Basically, all drugs have or seem to have some level of affinity for or attraction to albumin. For example, warfarin has a very strong affinity for albumin to the point where only 1% is actually freely available to cause any kind of therapeutic action. The other end of the spectrum, gentamicin, has a very weak affinity for albumin, making it so that there's 99% freely available in the bloodstream to do whatever it needs to do. What that means is if a person perhaps has low levels of albumin, that's going to make a very stark difference in the in how much of a dose we're going to be giving for warfarin, since if a person has a dramatic decrease in their albumin count, then their dose, the normal dose that we would give to someone with normal levels of albumin, might cause them to bleed out. We can give them the antidote for that, but the point is that we want to skip that and try to make that a dose that's appropriate for that patient. Whereas gentamicin, likely if they don't have any or if they have very low levels of protein, it won't make any difference because we're only talking about 1% that ends up getting bound to protein. So we're good. All drugs will be metabolized. No, that's not true. A lot, if not most drugs, will be metabolized at some point. And metabolism is simply the enzymatic alteration of the drug structure to help with elimination. And most of the time it takes place in the liver. And it helps to make the drugs more water soluble and able to be excreted through the kidneys. And we want that because we don't want to have drugs that we give people remaining in their systems forever, causing problems. We don't want that. So something that's super important here is the cytochrome P450 system. This is going to be a set of enzymes in the liver that are used to break down drugs and other stuff. Sometimes they can even activate certain drugs, such as prodrugs, to help make them useful in the body. They're actually inactive until the liver acts upon them with the P450 system. They can also enhance drug effectiveness, increase or decrease drug toxicity, such as converting them from being lipid soluble to being water soluble to allow for renal excretion. Blah, blah, blah. So each family kind of has been identified as doing certain tasks or breaking down certain types of medications. And there are a number of things, of course, that can affect. I don't think that's not the right form of effect. It should be an affect. Drug metabolism, so age, genetics, disease, nutrition, environment, other drugs. These can all affect the quality of metabolism. Certain drugs that you'll learn about will actually inhibit P450 metabolism of certain drugs, allowing those other drugs that were meant to be broken down to sort of run rampant and not have any, or have a much stronger, longer lasting effect because of that. So the substrate is going to be the actual drug that is metabolized by the P450 system. Inducers are going to be any drugs that act on the liver to increase the rate of metabolism on those drugs. So if you have a drug that's given to a person and that drug will induce metabolism of warfarin, then that means that that drug is going to cause the enzymes in the liver that break down warfarin to act that much faster making it so that you have to give more warfarin to ensure that warfarin stays in the range that we want it to stay in. An inhibitor is going to be the opposite. It's going to make things less likely to be metabolized, and so they're going to end up running more rampant through the system, and you're going to have to decrease the dose of those meds if you're giving them together. The first pass effect is a very interesting effect. So you've got a med that comes down from the mouth into the stomach, does this whole stuff in the stomach. It gets absorbed from the small intestine into the hepatic portal circulation, and from there it goes up into the liver. It gets metabolized, and then it leaves to go into general circulation. So most drugs, from my understanding, they do not go straight from, I guess it really depends on where they are. A lot of drugs will go with a lot of drugs. A lot of drugs will go from the stomach, small intestine, to the hepatic portal circulation into the liver without going really anywhere else in the body. They won't go into general circulation until they pass through the liver. So what that means is any medication that is very sensitive to the first pass effect might actually end up getting completely and totally metabolized on the first time through this cycle, making it a useless medication that you've basically you could have not given it and it would have created the same effect. Some medications that go through the liver can be broken down so quickly that, I'm making this way more complicated than it has to be. Certain medications go through and they get acted on really well, really strong, and they get taken out. So that would be a strong first pass effect. Some have a weak first pass effect, so they go through the stomach to the liver, and there's so much more left, it's not a big deal. But those medications that might get taken out completely, we have to give a different route. So for example, nitroglycerin. If we give it via a pill, which that would be an option if that worked, it would go through the stomach, small intestine to the liver, and it would be completely destroyed by metabolism. Instead, what we do is we give it either through an IV, or we give it sublingually so that it gets absorbed under the tongue, straight into the circulatory system, and it goes to action. It doesn't have to go through the liver because we didn't give it through the stomach. Hopefully that made more sense. Okay, excretion. So drugs are excreted through the body via many mechanisms. They can come out through urine, sweat, saliva, breast milk, bile, through enterohepatic recirculation, or expired air, which can occur through or with some anesthetics. Enterohepatic circulation is going to be where some drugs actually enter this sort of loop. They come down through the stomach, to the liver, through the first pass effect, but these medications don't have a very strong first pass effect. They go back through into the GI tract, and some from the liver leaves and goes to the tissues, some from the liver goes to elimination, but a lot of it comes back through to the GI tract and allows for this sort of long-term action, if you will. And the reason why is because it mixes with bile and gets reabsorbed into the liver and returns again to the duodenum. And so each loop that occurs allows some of the drug to be excreted and some to act specifically on tissues. I don't think I've seen that at all since this slide, but good to know about. So we've kind of covered a little bit the pH-dependent ionization. Let me make sure that I actually have this right. So a lot of things are going to be excreted through the kidneys. So this is the glomerulus, Bowman's capsule, down through the tubule, and we have also the blood circulatory system. So general routes for renal excretion, we're going to have glomerular filtration. So particles of drugs will come through the glomerulus into the tubule. Good. Some will have passive tubular reabsorption, meaning that they'll be reabsorbed from the tubule back into the bloodstream if they are lipid soluble. If they are not lipid soluble, then that won't happen. They'll maybe try or whatever. They won't be able to cross because they are not lipid soluble. So a polar medication or an ionized medication won't be able to cross through this barrier. There are some medications also that use active tubular secretion to help get out, where there are actual tubular pumps for organic acids or organic bases that these drugs will take advantage of to get into the urine, into the tubules, and out through excretion. Certain things can modify excretion. So, for example, pH-dependent ionization. If a medication is ionized, they will not readily pass through lipid membranes. We already kind of covered that. So the more ionized they are, they won't cross through. They will just kind of stay in here and go out. And another modifying factor is active transport between the blood, the circulatory system, into the urine. So if there's a lot of competition for those active transports, then as these meds are kind of coming down here and trying to get out, there may be too much competition here and they miss their chance and they go back into the body and they cause more of an effect that they are meant to cause, but they're in there longer than they should be. Newborn kidneys are also going to be really immature, and so they're going to be very limited in their ability to excrete medications. All right. I think that was all there was. I have a lot of red on there. So time course for drug responses. So when it comes to giving a drug, we want to make sure that our drugs we give have the appropriate minimum effectiveness so that we can actually cause an effect. But we want to keep it down below the toxic concentration. We don't want to make them poisoned. We want to keep them below that. This is going to be considered the therapeutic range, which is very similar to the therapeutic index. So on a more visual side, we give a medication, it's going up. We got to make sure we give a dose that's high enough to actually cross this minimum effective concentration. Once we cross that plateau, or not plateau, but that line, we are now in the therapeutic range. We want to make sure, though, that we do not give so much of a medication that we then pass through this therapeutic range and go to the toxic concentration range. Certain medications are going to be a lot more forgiving than others. For those especially that are a little less forgiving, or perhaps a patient needs a very specific kind of dose in their body to maintain a certain effect, we may have to do sort of this steady state, I think that's what it's called, there may be another term for it, action, if you will, of giving multiple doses on a regular basis to maintain a certain range or concentration in their blood. And that's based off of a drug half-life. So a half-life is the time required for the amount of the drug in the body to decrease by 50%. Some drugs have a half-life of a few minutes, some have a half-life of more than a week. And so the greater the half-life, the longer that drug is going to last in the body, causing some kind of an effect. When it comes to trying to create this plateau, as we can see here, this is a medication, for example. These are all days on the x-axis. This is the grams of a medication in the body. This person wants to have their medication concentration in the body. They have no idea themselves. It just happens to be. They want it basically kept at about 3 grams in the body. And this drug has a half-life of 1 day. So we give it on day 1. Over the course of 1 day, it's decreased by a concentration of 50%. On day 2, we give another medication, another dose of 2 grams. It's decreased by 1 gram. Nope. How does that work? It's decreased by 1.5 over that next day. But overall, the idea here is that over the course of 4 days, we have reached the proper plateau, the therapeutic range that we want, and we can continue to maintain that there by giving regular timed intervals of medications. So the highest dose, or the highest level per dose, is referred to as the peak concentration. This is all a little bit extra here. The lowest level is referred to as the trough concentration. The peak concentration must always be kept below the toxic concentration. So the highest dose that we end up giving them needs to remain below the toxic concentration. And the trough concentration must always be above the minimum effective concentration. That way we can maintain a constant effective effect, I guess. And sometimes you may have to give a loading dose, which is going to be what these guys, I think this guy here, maybe this guy are. But then we have the maintenance doses, which are the smaller doses, such as these guys here, to maintain this level of steady state activation, or whatever you want to call it. Okay, so now moving on to pharmacodynamics. Mechanism of action is a very important thing about meds. It's basically, what does the med do? And they can be, the mechanism of action can be either as a receptor interaction. They can cause the action, the effect that we want that drug to cause through interacting with receptors. And then there are some drugs that have non-receptor drug reactions or responses. So receptors are these chemicals that most drugs interact with to produce effects. And once those drugs interact with those receptors, they can either mimic or block the actions of the molecules that normally go into those receptors. And they can either increase or decrease the rate of physiologic activity that receptor, once activated, is supposed to cause. So for example, we can have agonists. So medications that are agonists are going to be ones that activate those receptors. And in order to do so, they need to have an affinity for those receptors, and they also need to have a high intrinsic activity. So the affinity is going to be the attraction. Intrinsic activity is going to be the ability of that drug to actually activate a definite positive activation of that receptor once they bind. We also have partial agonists. Partial agonists are only going to provide a moderate level of intrinsic activity. It's still going to have that affinity, but instead of having a high level of intrinsic activity, it's only going to have a moderate level of intrinsic activity. And based on what that receptor is designed to do, then that medication could actually be classified as either an agonist, like a partial agonist, or an agonist-antagonist. Because if that receptor is actually going off at a very high rate of speed all the time, then giving this extra medication or giving this medication that is only a partial agonist that only causes a moderate intrinsic activity will actually in some ways cause it to be almost antagonized. But there's still some level of activity going on. It's sort of like saying, we're going to put the brakes on this a little bit. You're still going, but we're slowing you down. An antagonist, on the other hand, is going to just completely block the effects of that receptor. They're going to have the affinity for that receptor, but they are going to cause no actual activity. They're going to block activity. So here we've got these little green guys coming in here to this receptor site. These are the endogenous chemicals, the natural ones that are in our body coming in and causing some sort of an action. They come in, bingo, cause a reaction. The agonist is going to do the same thing, perhaps just bump it up. The antagonist, though, is going to come in here and they're going to plug these guys up, these receptor sites, so that these natural endogenous chemicals can't get in there and activate the receptor to cause the action. And when we have antagonists, we can classify them either as being non-competitive or competitive. So non-competitive is going to be where they are able to bind irreversibly to that target receptor. But irreversible does not mean permanent, because as with everything else in our body, those receptors are going to eventually die off, some much sooner than others, and that's going to leave us with a new receptor that is able to function. So it's a temporary solution. But while that receptor is there, nothing else can compete with that receptor site. That chemical, that drug that we gave them that is non-competitive is not going to allow anything else on there. And so we can either reduce the number of receptors that are available, or we can block all receptors altogether. There's no response possible. A competitive antagonist is going to be one that is going to, as the name implies, compete for those receptor sites with the endogenous chemicals that are meant to go on there. And whichever one has higher concentration in the blood is going to be the winner, basically. So we also have receptor sensitivity. And receptors are going to be dynamic cell components. The number and sensitivity of receptors on a cell surface can change in response to continuous activation or continuous inhibition. So if we have a receptor, let's say insulin, insulin's not a receptor, but the receptors that insulin affects on cells to get glucose to go into those cells. If we are eating a tremendous amount of sugar on a very regular basis, we're going to be constantly producing insulin. That insulin is going to constantly be targeting those cells, saying, hey, open up, we got more sugar. And that's going to eventually desensitize those cells from opening up. And that's how we get insulin resistance. Those cells literally become resistant to insulin. Now suddenly we have a whole bunch of sugar running course through our blood vessels, causing inflammation, irritation, potentially atherosclerosis, just bad juju. So that's why people are saying we got to make sure that we're becoming more insulin sensitive. We want insulin sensitivity. Continuous inhibition, continuous inhibition is going to then lead to hypersensitivity as opposed to desensitization. So in that case, we're going to have, I don't remember or know off the top of my head a situation like this, but what we can have is a receptor that, because of how infrequently it is turned on, that receptor, once stimulated, is going to have a much more profound effect compared to one that is targeted and activated on a regular basis. There are some drugs that do not involve receptors and produce simply a physical or chemical interaction with other small molecules. Antacids, they themselves are a base, and so you take them and they neutralize the base or neutralize the acid in the stomach. Saline laxatives, I don't know what a chelating agent is, antiseptics. That's basically it. Individuals can also have different responses to meds, and the dose required to produce an effect in one person can be a very different response required, or a very different dose required to produce an effect in someone else. So like, for example, pain meds. One person can have a very high tolerance to pain meds requiring very high doses to create an effect. And then there's me, who you give me a single Percocet and I'm out for 12 to 18 hours. Very different people. So we need to be aware of interpatient variability. So for example, we have the effective dose, or ED50, is going to be the dose required to produce a defined therapeutic effect in 50% of patients. So these are measurable or measured via studies to determine what is the effective dose for 50% of the patients. And then we have the lethal dose, or LD50, is the dose required to produce lethal effects in 50% of patients. And then the therapeutic index, important term here, is the lethal dose in 50% of patients divided by the effective dose in 50% of patients. And so that will create this range, therapeutic range or therapeutic index of where your drug dose can go. So for example, we've got here drug X. Drug X has a lethal dose of 100 and an effective dose of 10 in 50% of the population. So that means that we've got this massive range between the lethal dose and the effective dose. So I mean, you can kind of, let's say for example, a mistake was made and the wrong medication dose was given. Not so big of a deal because this dose or this drug has, I mean, it's a big deal, but not from the perspective of actual patient responses to it, because there's such a massive range here. Now, drug Y, let's say this is something like lithium, which is given for bipolar disorder. This has got a very tiny range between the effective dose and the lethal dose. So this is one where if you mix up on the dose of the medication, you could then actually kill the patient much more easily than you can with drug X. Okay, so there are lots of drug-to-drug interactions, and it doesn't help that a lot of patients are on so many medications, and it doesn't help either that we have so many over-the-counter medications that patients don't talk to their doctors about before starting or have enough knowledge about that drug to know for sure whether they can take it. And then we have all these supplements that aren't even regulated by any actual authoritative body, and some of which can actually cause some very severe interactions with prescription medications or over-the-counter medications. Some patients need multiple drugs to treat one disorder. Some patients have multiple disorders that require different drugs. Reactions are just all over the place. Drugs, though, can interact through 4 basic mechanisms. I didn't really understand this completely. They can have a direct chemical or physical interaction, which normally renders both drugs inactive and can often form a precipitate. This is an example of a precipitate. This is an IV tubing, and this is a very large zoomed-in view of it. All of this is precipitate that has developed inside the tube from the 2 drugs interacting. These never go in patients. These are very, very bad. They will cause lots of damage. We can also have pharmacokinetic interactions, pharmacodynamic interactions, and combined toxicity. We've got 2 things that themselves together are or either on their own are toxic. They form together to create an even more profound toxic experience. Don't kill your patients. You're not. There are lots of checks and balances, but be safe. There are also going to be drug-food interactions, some of which are very strong, and a lot of times they are very poorly understood. The drug interactions can increase drug or can affect drug absorption to either increase drug absorption or decrease it, affecting the time of administration. So we may need to give it like 2 or 3 hours before the first meal of the day. It can affect drug metabolism, such as grapefruit. Grapefruit is one of those meds that affects one of those foods that affects so many meds. It's better off just not to take it. A lot of times, that'll end up with an increase in levels of that medication because the grapefruit will inhibit the P450 enzymes that are used to break down those meds and metabolize them for excretion. Drug-food interactions can also affect the drug mechanism of action. And then, like I said, there are drug supplement interactions. For example, what is one that is? The St. John's wort is, I think it's used for pain. It's a weird name. But it is used, or when it is used on a regular basis and not told to the doctor, there's a high chance of interacting with other meds that that patient is taking. Adverse drug reactions come in other terms as well, like side effects, allergic reactions, toxicity. Lots of different terms can be used for this. And it's any noxious, unintended, and undesired effect that occurs at normal drug doses. So if you get a bad effect, but that's because you quadrupled the dose of that medication on accident, that's not an adverse drug reaction. That's you making a mistake. The effects of these reactions can range anywhere from being an annoying pest, a little bit of itchiness, no big deal, to life-threatening anaphylaxis, effects on the heart, on the lungs, lots of things. They are most commonly in the elderly and the very young because those are the people who are most susceptible to any kind of drug issues. Their metabolism systems are not going to work as well. Their excretion systems aren't going to work as well. And they are simply more susceptible to the medications to begin with. And then your system also is under a lot of stress when you have severe illness. And that's going to make it more likely for those drugs to have a stronger normal effect to begin with. And anytime you have a stronger normal effect, you're going to have that much more likely of a chance of having an adverse drug reaction. And then also your immune system may even respond differently to the medications when you're sick compared to when you're in a normal, healthy state. So the higher number of meds or drugs that a patient is taking, the higher the risk for a serious drug interaction. Communicate with everyone to make sure that you're actually giving the right meds and reducing drug reactions. Black box warnings are the strongest safety warning in drug and carry. So 90% of all drug errors or medication errors are due to human factors, communication mistakes, drug name confusion between the generic or the brand and trade name. That happens a lot. And there are now, thankfully, a lot of different types of safety nets that are created, especially through technology to help reduce the chances of these human errors. Overdoses are very common at 36%. Wrong drugs are given on a regular basis, as are the wrong routes used to give certain meds. We want to promote a culture of safety. Individuals can vary in how they respond to drugs. So if they don't take the medication as prescribed, if they have poor adherence, which is a common thing with a lot of patients who simply don't like the effects of their medication or they think that they don't need the medication, then that will change how the person responds to the drugs. They can have a placebo effect. They can have changes based on the race or their sex, body composition, and weight. Having higher fat or lower fat proportions, their tolerance to, for example, opioids, and the absorption variability, how well they're able to actually break down and absorb those medications for causing an effect. Their age, diet, genetics, pathology. I think everyone's pretty familiar with a placebo effect. So when it comes to bioavailability, I'm going to skip that. So make sure you're staying good on your 6 rights: the right patient, right drug, right time, right dose, right route, right documentation. These fit into that. I don't remember seeing these. But this is also very important, right reason, which would be the right drug, or falls under right drug. Do not administer if you don't understand the reason for using that drug. I think that's it.